Hi everyone, good evening and welcome to the Terumo Learning Edge Radial First Go Everywhere with Glidesheath Slender. My name is Jennifer Masabini and I am a Senior Education Manager here at Terumo. I'm joined here with my colleagues Ellie, Ilka, Yara, and Sydney supporting the virtual side of this recording. I have a few housekeeping items that I would like to go over. First, this presentation is intended for US physicians only. Products may not have regulatory approval in all countries, so please contact your local sales representative if you have questions about the availability of products in your area. This will be a recorded roundtable discussion, so if you have any questions regarding the topics discussed or looking for any further Terumo education opportunities, please visit us at www.terumois.com or reach out to your local sales and clinical representatives. We have a great event planned this evening, and leading the discussion will be Terumo Senior VP, Chief Medical Officer, Dr. Michael Martinelli. Dr. Martinelli is an interventional cardiologist with over 20 years in practice, and I would say probably one of the true pioneers in radial access. So with that, thank you all for joining us tonight. And Dr. Martinelli, the floor is yours. Thank you.
Thanks, Jen, and hi, everybody. And thank you for giving us your time this evening. We have a real esteemed panel to discuss something that's near and dear to our heart here at Terumo, and that's radial access. First, we'll start out by making some introductions. So why don't we go around the horn and introduce ourselves. I'm Mike Martinelli, as Jen said. I'm the Chief Medical Officer for Terumo. My experience is in interventional cardiology. And then we'll go to Dr. Peebles.
Hi, I'm Todd Peebles. I'm a neurointerventional radiologist in Wisconsin. I've been doing neurovascular procedures through the wrist for about 6 years.
Great. And Dr. Resnick is next.
Hi, I'm Dr. Neil Resnick. I'm an academic interventional radiologist in Atlanta, and I've been doing radial access for just over a decade now, 2012.
Great, welcome, thank you. And Dr. Zhiroff.
Good afternoon, I'm Katrine Zhiroff. I'm an interventional cardiologist in Los Angeles. I've been doing coronary procedures through the radial since 2012 and peripheral vascular procedures probably in the last 5 years or so.
Thank you. And last but not least, Dr. Skripochnik.
Hi, Eddie Skripochnik, vascular surgeon in New York, New York Presbyterian, Columbia. I've been doing peripheral interventions from the wrist since about 2016-ish.
Great. All right. I just want to throw same-day discharge out there because since we've been developing the whole radial programs since the inception of radial years ago, we've been kind of pushing towards quicker discharge and in cardiology at least same day discharge. I know that cardiology and vascular surgery are doing a lot of same-day discharge. Are we seeing that in other areas? Can you guys comment on that?
From a neurointerventional perspective, a lot of the patients wind up staying overnight in the hospital anyway. So there are a few exceptions. Lately, we've been doing more, like middle meningeal artery embolization for subdural hematoma, for example. Those people can go home right away because they come in as outpatient. I think in my experience for neuro, the biggest impact it's made is how much it has shortened the duration people stay after diagnostics. We do a lot of diagnostic neuroangiography, and really our protocol now allows people to get out of the hospital within an hour. And so those are, that's a real saving in terms of beds and personnel time, et cetera, which is a big benefit for the system.
Right, you don't have to go all the way to the end of the spectrum of same-day discharge for interventions, but you're still getting benefit in patient throughput all the way around. How about in cardiology, Katrine? Do you you're doing a lot of same-day discharge? I know we've had this conversation.
Yeah, I mean, I think actually, COVID, the silver lining was that I think people became hyper aware of the shortage of beds, and it's not just the bed; it's the amount of human hours involved in taking care of a patient. So I think doing radial for same day discharge has, just gives people so much more confidence that it's okay for the patient to go home, both just from the patient comfort, but also from the staff. And I really like the fact that I can really walk the patient around before they go home after a coronary intervention. And I think it gives the patient confidence, I'm okay going home.
Yeah.
So yeah, I think it's been really great. And same for the diagnostics. For the patients that come in for coronary diagnostic angiogram, they go home within an hour. So it's been really good.
Yeah, the hospitals love it. And how about you with vascular surgery procedures? You probably do a lot of patients that can go home.
Well, I would say it's more crucial in the outpatient setting. In the hospital, they're usually there. Our patients are also pretty sick from other standpoints, so they end up staying. But I'll tell you this, that if you're new out there and all of a sudden you come into a location, you start doing radial access, the PACU will quickly learn your name because you're able to shunt the patients out very quickly and ambulatory right away. So that's a huge benefit for the hospital system and the operating room staff and administration as a whole.
Yeah. The inpatients, it's a different story in vascular surgery. I understand, you have chronic limb ischemia, you have all kinds of other issues with the patients, but you're right. The outpatient setting is a perfect place for radial. How about in radiology?
Yeah, definitely. For our fibroid embolization patients, for example, this is a great way to get the patients out even sooner and ensure they go home the same day. And I find for these patients, the added benefit is that, I'm a male physician and it's a women's health procedure and it's kind of nice. We're not even at the groin or anything like that. So that I think that's helpful. And even just for some of our patients who are again bleeding or coagulopathic, this kind of thing, we can feel more confident doing procedures, period, inpatient or outpatient, by radial access, where in the past, sometimes we felt uncomfortable even moving forward with the interventions with going from the groin.
Yeah, that's a great point. Great point. There is, one other issue that's really specific to cardiology, and that is sending patients home same day who have complex interventions. Now that we know that there are more, we can do most complex interventions through a 7 French sheath. The Glidesheath Slender offers that through a 6 French access. Anything that you could expand upon there, Dr. Zhiroff?
I think, it's become more about the intervention itself than access. I think, we used to dread the midnight call that someone's having belly pain or they're hypotensive and you had groin access, and it becomes this huge stress of what's happening. Are they bleeding? So for us, if it's a complex intervention, but everything went according to plan, there were no complications, no dissection, no reflow, I'll usually keep patients extra long. They'll stay for about 8 hours post procedure for monitoring, but they're still going home.
And that would be for a complex PCI.
Yeah, even something like, if you're even for left main, as long as everything went fine, most of the stuff that you're worried about is their access, and with radial, that gives us enough time to monitor it.
Great, thank you. I think, we pretty much covered the gamut here. Does anybody have anything else, any pearls that you'd like to add to this conversation regarding radial access, glide sheath, the nuance of best practices?
No, I guess the only thing, going way back to when you started asking about best practices, the only thing that I think I would add to that is, trying to educate patients about aftercare of their wrist before the procedure. I find very helpful because especially, they're not going to remember things if you go over all the post-care after they've been sedated and had their procedure. So I've definitely switched to pre-educating people, and with the aim of trying to prevent any of those unusual delayed bleeding complications.
That's a great point. It especially comes into play in the same day discharges, because they're going home a couple hours and they have no idea what to do with that wrist if it starts to bleed. It's great. Anybody else have any?
I wanted to mention something we spoke about kind of tangentially, and that's the role of anticoagulation. And
Yes.
I think what I find, especially for cardiology patients, someone who has atrial fibrillation and chronic anticoagulation, we don't need to hold anticoagulation as long. If the
Great point.
patient's on a DOAC, I usually just have them hold that dose that day. We do the procedure and they restart. So their hold time is truly less than 24 hours.
Great. Yeah, that's really important. That's the way we sort of sold Radial in the very beginning. You could do somebody who's fully anticoagulated and still get the sheath out and have no significant increase in bleeding. One thing I actually wanted to raise just out of my own interest, and that is the use of the ulnar. It was mentioned early on when we were talking about ultrasound, and that's a great use for ultrasound to see if you have a good ulnar. Are you all using ulnar access if you don't have an acceptable radial, either size-wise or disease-wise?
I don't. I usually have another option.
Okay.
I don't have that.
Yeah, I will go ulnar if I need to. Like if you encounter a loop or you know there's a loop or something, you can try ulnar. Keeping in mind that you can, for a lot of things, at least diagnostic things, and some interventions from neuro, you can use the left side as well. But I think ulnar is a very viable but not often used route.
I'll usually go to the contralateral radial, and then if for some reason, that doesn't look like a good size, if there's a lot of calcification, I will go for ulnar. And I think to your point, ulnar ultrasound is always, should always ultrasound for ulnar access. And I think it becomes a little bit more challenging to get good hemostasis, which is also why I like using ultrasound to make sure I'm getting access over like close to a bony prominence.
Yeah, I agree. Yeah, I hear you. Well, thanks so much, everyone, for all your time and your expertise. We really appreciate it. I think that these types of discussions are really beneficial for our audience, and we're certainly grateful to have real champions like yourselves. So thank you very much, and we really appreciate all the time you spent.